If you've worked in healthcare for, say, the last decade, you're probably just exhausted by the tech cycle.
Oh, completely.
Every few years, there's this huge new wave EHRs, patient portals, digital transformation, and they all promise so much.
And so often, those promises feel, well, a little incomplete. They end up dumping more admin work on the very clinicians they were supposed to be helping.
Exactly. So that experience, it creates a very natural skepticism.
It does. And when we start talking about this current explosion in AI, especially generative AI, that caution is more than warranted. We're talking about real patients.
Real clinical workflows.
Real legal and safety risks.
Mm.
Nobody wants to chase some expensive tech fad just to end up with more digital clutter.
Right. So the impulse is to wait and see. It feels like the safe play.
It does. It feels prudent.
But our sources for this deep dive are suggesting that holding back is, well, it's about to shift from a prudent strategy to a major strategic risk.
That is the absolute core thesis we have to tackle today. The data is showing that 2025 isn't just another interesting year for AI. It is a critical tipping point.
Okay, a tipping point. What's driving that?
It's three things that are all hitting maturity at the same time. First, just the unprecedented velocity of financial investment. Second, a sudden, really aggressive jump in adoption by doctors and hospitals.
And the third.
And third, the fact that the core use cases are, frankly, finally mature enough to deliver immediate, measurable ROI.
Okay, let's unpack all of that. If 2025 really is this quiet deadline, then our mission for you, the listener, is clear. We need to understand exactly why waiting isn't a neutral option anymore. And, more importantly, where you should focus your first moves to make sure AI actually serves clinicians and patients, instead of just creating shiny, siloed projects.
We have to get past the promise and into the operational reality of it all.
And the best evidence for that reality starts with where the money's going. Let's just look at the sheer market acceleration that's defining this shift.
The money is flowing like never before. I mean, the projections are staggering. What's fascinating is just the velocity of it.
Okay.
The global AI and healthcare market size was estimated at around $26.6 billion in 2024.
Which is already big.
That's already big, but the trajectory is what really matters. It's forecasted to grow toward almost $188 billion by 2030.
Wait, say that again? That's nearly an 8-fold increase in just 6 years.
Exactly.
So the KGR, the compound annual growth rate, that's got to be, what, close to 40%?
It's around 38 to 39%. That's a growth rate you usually see in, brand new emerging tech, not in an established sector like healthcare.
Right.
And for 2025 specifically, we're looking at about 38 to 40 billion. The key takeaway here isn't just the number, though.
What is it?
It's that this isn't just funding for some esoteric research lab anymore. This level of investment means this is now core digital infrastructure, and it's competing directly with other major capital expenditures. This is no longer just experimental spending.
Okay, but money by itself doesn't prove it's working. It just proves investors are optimistic. You need adoption. Are providers actually using this stuff?
They are, and they're integrating it fast. The mainstreaming is undeniable, especially when you look at how it's connecting to the electronic health record.
The EHR, the system of record.
Exactly. In 2024, 71% of hospitals said they were using predictive AI that was integrated with their EHR. That's up from 66% the year before. So institutional buy-in is solidifying.
But the jump for individual doctors, for physicians, that's where the story gets really interesting.
That's the one.
Our sources are highlighting a jump in physician usage from 38% in 2023 to 66% in 2024.
That is the data point that just screams tipping point. It literally went from a minority activity, something only early adopters were trying, to a majority activity in about a year.
Almost overnight.
Almost overnight. And that tells us that the first wave of AI tools, the ones targeting those immediate nagging efficiency problems, have finally proven their worth in the clinic.
So if adoption is spiking, the ROI must be getting clearer. What are the sources saying about the actual measurable return?
It really boils down to two things: capacity and time. McKinsey estimates that in a sort of midpoint scenario, about 15% of all healthcare work hours could potentially be automated.
15%. Just think about what that means.
Yeah, think about what 15% of your staff's time currently spent on documentation or routine calls could translate to in terms of patient throughput or, just as importantly, reduced burnout.
And that gets us right back to the strategic risk of waiting.
Yeah.
If I'm an early adopter and I reclaim 15% of my staff's time this year, I'm immediately building an advantage in recruiting and retention and margin.
Precisely. Early adopters are building these compounding advantages. They move faster, their staff is happier, their patient flow is better. And the flip side is the risk for those who wait.
Oh, so?
If leadership says, you know what, we'll wait a year, they aren't actually standing still. They're running a massive risk of uncontrolled shadow AI just popping up everywhere.
Let's define that for the listener. What exactly is shadow AI?
Shadow AI is when, say, an individual department or even a single clinician goes out and finds their own cheap, narrow tool, a little documentation helper, a private scheduling bot, and they buy it with a credit card.
Bypassing IT completely.
Bypassing IT, bypassing procurement, and crucially, bypassing governance. It solves one tiny problem right now, but it creates this massive fragmentation, security headaches, and technical debt that leadership absolutely will have to clean up later.
So you delay the strategic move, and you just accumulate uncontrolled risk instead.
That's it. It's a powerful incentive to move deliberately right now.
Okay, the financial and adoption signals are crystal clear. So now we need to move from the why to the what. Where is AI actually delivering real practical value today? Let's dig into the 4 domains our sources highlight as being proven, practical, and, really tied to saving time and money.
We have to start with the biggest one. The biggest pain point for clinicians: documentation.
The sources call it the tax everyone pays in digital medicine. It's the #1 driver of burnout. I know doctors who finish their day and then spend 2 hours in their car at night finishing charts.
That exact scenario is the one AI is solving most effectively right now. The technology gaining the most traction here is called ambient AI scribes.
Okay, how does that work?
The system basically listens to the patient-clinician conversation, with full disclosure and consent, of course, and it instantly turns that dialogue into a structured medical note draft.
So it writes out the HPI, the exam, the whole plan, all ready for review.
Exactly. The history of present illness, the assessment, the plan, it's all structured. And the clinician is still fully in charge. They review it, they edit it, they sign off. But that heavy cognitive load of trying to listen, treat, and type all at the same time, it's just gone.
What are the measured benefits we're seeing from that?
They're profound. They touch efficiency and well-being. Studies show real reductions in time spent on notes, often freeing up 30 minutes or more per day per clinician.
That's huge.
But the most crucial data point for me is the measured decrease in clinician burnout scores, sometimes in as little as 30 days. Large health systems are now saying they're returning tens of thousands of clinician hours a year back to patient care or just personal time. This is a direct lever for staff retention.
A clear win.
Yep.
Okay, if we give time back on documentation, that time has to go to high-value patient tasks. But one area that still eats up so much time is that administrative black hole of referral management.
Ugh, the referral black hole. It's a huge patient safety and satisfaction problem. It's when a primary care doc sends an order, maybe by fax or phone, and then crickets. The patient just waits.
And the referral stalls because some piece of information is missing or nobody knows if the specialist has capacity.
Right. And that's where AI intervenes. It transforms that passive manual process into a proactive, intelligent one. It starts by classifying and prioritizing referrals by urgency.
Okay.
But crucially, it acts like a digital checkpoint. It automatically checks the referral for missing attachments or required fields before the order even leaves the system.
So it prevents the stuck referral before it even gets stuck.
Precisely. And for the patient, it can orchestrate updates through text or email, keeping them in the loop. It highlights cases that have stalled, the ones sitting too long in a queue for care coordinators, so they don't have to manually dig through hundreds of records.
That has to have a massive impact, especially for a large health network.
It's a direct lever on network performance. You reduce readmissions, you lower the risk of no-shows because patients are engaged, and you improve satisfaction, especially in complex areas like post-acute care or behavioral health.
Okay, let's move to the third area, voice AI agents. I think when most people hear voice agent, they think of a frustrating customer service call.
And that's fair. But in healthcare, the use cases are very structured, which is why they're so mature. This is mainly about reducing staff burden on routine tasks.
Like what?
Think about the sheer volume of outbound calls for appointment reminders, medication refills, pre-visit instructions. An AI agent can handle those reliably, 204/7.
And what about inbound calls? Can they handle more complex questions?
For inbound, they can answer basic things, office hours, directions, or just efficiently route the caller to the right human team, which gets the patient off hold faster. They're also really effective for structured follow-up check-ins after a hospital discharge, helping to flag early warning signs.
So the impact is really about taking pressure off the frontline staff.
That's exactly it. Less time on routine calls, lower no-show rates, and it helps high-risk patients comply with their care plans. But, and the sources are very clear on this, there is one non-negotiable requirement.
Transparency.
Total transparency. Patients have to know they're talking to an AI, and a human staff member must always be able to override the agent and step in immediately if things get complex and sensitive.
Right. Control and transparency are the bedrock of trust. Okay, finally, let's talk operations and capacity management. This is the fourth domain, where small efficiency gains can translate into huge financial leverage.
And this is all about shifting from reactive firefighting to proactive planning. AI is being used to forecast admissions and ER volume, not just generally, but by specific service lines. It helps optimize bed assignments, discharge planning, and even staffing and OR scheduling.
Most hospitals I know still rely on historical averages for that stuff. If AI can forecast ER volume even a little bit more accurately, what's the actual effect?
It changes everything. Even a modest gain, a few percentage points in forecast accuracy, or a small reduction in avoidable idle time in the OR that translates into millions in financial impact for a large system. You go from constantly shuffling nurses or canceling procedures to dynamic, optimized staffing. That ability to be proactive is critical when every health system is facing staff shortages.
Okay, so we've established the why, the money, the adoption, and the what, the four proven domains. Yeah. Let's pivot to strategy. If 2025 is the deadline to move from experimenting to operationalizing, what are the biggest traps leaders need to avoid?
Experienced leaders, the ones who've seen tech waves fail before, are consciously avoiding three clear pitfalls. The first is what we touched on earlier, isolated AI tools without a long-term plan.
So why are those point solutions so tempting and why are they so dangerous?
They're tempting because they're fast. You can fix one narrow problem tomorrow, like an ambient scribe in one clinic. But they don't integrate with your central identity or your data governance. They become that shadow AI we talked about.
Creating technical debt.
Exactly. You need a modular architecture. You need systems that use standards like FHIR APIs. That's the digital plumbing that lets healthcare systems talk to each other securely.
The second trap feels like it's about the human element, which is always the real challenge in healthcare tech.
It's the biggest bottleneck. The trap is deploying AI that sidelines clinicians instead of supporting them. If a doctor experiences the AI as just more clicks, or if the outputs are a black box they don't understand, or if it's just a mandatory IT push, adoption will stall, period.
So if the design isn't clinician first, with transparent controls and minimal friction, you're not going to get the ROI.
You'll fail. It doesn't matter how good the tech is. If the staff hates it, it's useless.
And the third trap, this seems to connect back to that plumbing problem from the first one.
It's about underestimating the data and integration effort. Look, these tools, voice agents, ambient scribes, predictive algorithms, they all need real-time, clean interfaces into your core EHR and scheduling systems.
This isn't just a simple software update.
Not at all. It requires robust identity management, detailed consent tracking, reliable monitoring for safety. You have to treat it like an extension of your organization's mission-critical nervous system, not just another app.
Understanding those traps is so crucial.
Yeah.
Okay, let's finish with the practical path forward. If you're listening to this in 2025 and you know you need to start operationalizing AI, what are the deliberate first moves?
The sources outline a very practical four-step path for this year. Step 1, choose 3 to 5 high-value workflows. Sit down with your clinical and operational leaders and find out where the most time or money is actually being lost today. Don't chase novelty. Focus on the low-hanging fruit. Documentation, referrals, patient call volume, capacity. Just narrow the focus so you can measure the impact.
Once it's narrowed down, step 2 is about defining the goal, but in a really accessible way.
Absolutely. Define success in plain language. You need a measurable goal you can explain to a busy clinician in one sentence, like, we will reduce after-hours documentation by 30%, or we're going to cut no-shows in specialty clinics by 15%.
That simplicity drives adoption.
It drives adoption and lets everyone know what the mission is. And you have to set a baseline metric and have a 90-day follow-up plan to hold yourselves accountable.
Step 3 addresses that integration challenge.
Yeah.
You need help.
You must work with partners who speak both healthcare and AI. You can't just pick a generic tech vendor who doesn't get clinical workflows or the nightmare of integrating with an EHR using FHIR APIs. You need vendors with proven expertise in these specific areas. documentation, referral management, voice AI, and who know how to design for that clinician-first experience.
And finally, step 4 is about deployment. Pilot quickly, but design for scale.
Right. Start small, one clinic, one call queue, but use production-grade security and governance from day one. Don't treat it like a sandbox project. You continuously capture what you're learning, show that measurable success, and refine your roadmap, always thinking about where that pilot goes next. By the end of 2025, you should have a living AI portfolio tied directly to your strategy.
This brings us to the close of our deep dive. The sources really make a compelling case. 2025 is this quiet deadline.
It is. The investment is undeniable. The market acceptance is there. The gap is widening now between organizations that are experimenting and those that are truly operationalizing. And the requirements aren't that complex. A short list of high-value workflows, a simple definition of success, and 1 or 2 trusted partners.
Ultimately, the pressure you're facing in this moment is purely strategic.
Boards won't be asking, why didn't we try more AI experiments in a few years?
No.
They're going to be asking, why weren't we ready when it was obvious AI could help our clinicians, our patients, and our margins?
And the challenge for you, the listener, is to use 2025 to start answering that question on your own terms with clear, measurable priorities before that question gets asked of you.